Good morning, everyone. This is a case, we did some palate expansion and we're completing the Invisalign, or we're starting to complete the Invisalign. So this is midway through treatment, but I just wanted to go over how well this palate expansion case went. This patient is in her 50s and she presented with a very narrow V-shaped arch. If you're ever wondering how to best compare where you started and where you are now, click on this little tab down here, starting from the current ClinCheck. So I was in treatment plan 7, that's here. I click on this guy, and actually this guy down at 1, which allows me to see the two cases where we started and where we are now. There's no other way in Invisalign to do this. I've been trying to get them to do it. Fortunately, I'm the only doctor in the world that wants to know where they started and how they've progressed, good or bad. With that said, what I'm going to do is flip to the maxillary. This is where she started and this is where she is now. Just from visual inspection, it's very easy to see how much expansion we've gotten. I think it's super important to know that any dental conference I've ever been to that talks about palate expansion, everybody argues about whether or not you can open the suture or not. And I can't tell you where my source is, but I have found the answer. And if you're curious on how I came to this conclusion, happy to share it with you. We do not get palate expansion from opening of the suture per se. We might get some there, whether or not it's really not that important, because the majority of the expansion comes from alveolar growth. When we push bone, segments of bone with proper force, we stretch the bone, and that stretching causes bone growth. That's the Wolff's Law. When you put force on bone, bone will grow. So what happens is if we push laterally, here we're actually going to get alveolar bone growth right in this area right here. We're actually going to get growth that way. I know this because we use the Carrier appliance and we apply a distalizing force to the upper segment of posterior teeth. We don't get translation of the teeth. We get increase in sagittal bone growth as we grow, as we apply that force. But my point is, it's important to know what's happening when we're doing this. We're getting actual new bone. Super earth-shattering for me, and I don't know if anybody's actually articulated that. I share that with you not to say I've found the secret keys to the kingdom, but I think I have. So anyways, this patient here started with an intermolar width. So we're always looking at the distance between the most medial portion of the first molars. What I'll do is I'll line up with this toggle all the way to the left. This is where the patient started. This vertical line here being 0, and then I have the starting point be a line, horizontal line. And if we measure, we have 10, 20, 30, 30 and a half, somewhere in there. How I orient this can change how that measurement occurs. I'm more interested in comparing apples to apples. With that said, 30 is a very narrow arch. We like 38 to 40, 42. Most patients are probably going to be somewhere between 32 and 36, which is still deficient, but better than a narrow arch like this. So this patient starts around 30 and a half. Then I'm going to come to this side here, and I'm going to do the same thing. I'm going to line up this little crosshair to end up on the medial part of the same tooth that I did on the left side. And I'm going to come over 10, 20, 30, 37, maybe 36 and a half. This is substantial. This patient's been in the palate expander for 9 months, which is a long time, but the patient's in for the long haul. And you can see all of the openings that are created in between the anterior teeth. The reason why I know that this is alveolar growth is because we're getting opening in all of the anterior teeth. My confusion began when I took a course with Ben Miraglia, and he talked about Moralia, and he talked about how wonderful these palate expanders are. This is where we got the concept. But when I asked a question after I'd done a couple cases, he wasn't able to necessarily articulate it. And the question was, if we're getting suture opening, we should see all of the expansion in between the front two teeth. What I was finding was the space that I was creating in the appliance did not correspond to the width of what I was seeing in between 8 and 9, and it just didn't make any sense to me. That's because we're not getting 100% opening of the suture. We're actually getting alveolar bone growth. I'll dive more into that concept of comparing the expansion of the upper removable expander at another point. But as you can see here, we got 6 to 7 millimeters of expansion. Now I have space to straighten out the teeth. Look at that arch. That would not have happened here without expansion. You can imagine what this would have looked like had we not created the space. Let's just see what they did. Yeah, getting that kind of expansion with Invisalign trays alone is not going to happen. That's just not in the cards for the plastic. All right, so in a nutshell, we had been doing the lower arch. We always do the lower arch at the same time. So lower Invisalign trays, upper expander. No different than when we use a Kyrie appliance, and this is actually, it's not where we are now. That's where we are now. Obviously much improved, and we're going to continue leveling the curve of Spee to resolve her deep bite and then go from there. All right, I hope this was helpful, and if you have any questions on removable palate expanders in adults, I will happily have a discussion. Thank you.